event. We call it the Primary Care Work Group for short. We have about 20 people online. This is a fully remote meeting, and I'm going to ask staff to introduce us to everyone that's online at the moment. When you speak, if you want to give a brief introduction to yourself, that's fine, but we're not going to go round robin at the present time.
Thanks, Ben, and good afternoon, everyone. To get us started, Anani will complete the introduction, and Melanie will make a few opening remarks. Please proceed, Anani.
Thanks, David. Good evening, everyone. Thank you for joining the meeting this evening. We would like to remind everyone that the meeting is being recorded. Please contact the MHCC team with any technical issues. We sent an email Friday with the team's contact information. As a courtesy to others, please remain on mute when you're not speaking to reduce background noise. Staff may mute you if there's a lot of background noise coming from your line. You can also mute and unmute yourself using the small button at the bottom of your screen that looks like a microphone. We have a couple of presentations this evening. Please hold all questions until the end of the presentations. At the conclusion of the presentations, you may raise your hand by clicking the raise hand button under reactions at the bottom of your screen. Another option is to enter your questions into the chat box. The meeting facilitator will sequence speakers and may also call on people to speak to ensure that we have a range of perspectives. If the speaker is not able to answer your question during the meeting, the speaker will respond via email after the meeting. So before we begin the meeting, I would like to recognize the work group members who are attending the meeting today. I see the following people. Dr. Amar Dugirala, Mr. Chad Paman, Ms. Christina Kaminsky, Dr. David Sharp, Mr. Ben Steffen, Dr. Bernstein, Mr. John Miller, Ms. Karen Lamb, Ms. Kathleen Logren, Mr. Kenna Eats Trotman, Ms. Laura Goodman, Ms. Laura Russell, Ms. Mary Jo Condon, Ms. Matt Ramnathan, Dr. Michael Barr, Ms. Nora Hoban, and Mr. Shanka Mesta, Mr. Ron Gresh, Ms. Trisha Roddy, and Ms. Tracy DeShields, as well as MHCC staff, Mr. Ose and Marcelo. Is there anyone I'm missing at this time who would like to introduce themselves?
All right. I'm going to pass it over to Melanie. You have a few opening remarks, Melanie.
Yes, thank you, Ben. So good evening. I just want to thank everyone for who participated in the subgroup meetings. So we made some enormous headway in the framework for measuring primary care investment. So today you'll hear some of the subgroups recommendations, including the priorities. So the framework is iterative and may change as we progress. The activities so far help us understand what we're looking for as we define primary care. So I'm going to review a slide shortly that will show where we are in the progress of drafting a plan for the report and analysis. So our consultant, Mary Jo Condon from Friedman Healthcare, will review the measuring progress towards primary goals table and priorities developed by MHCC staff and subgroup. We will also hear presentations on primary care investment. So at this time, I'm going to turn it back to David to see if he has any comments.
Thanks, Melanie. So just to amend a statement we talked about a few minutes ago, Anani, our chair and ED, has suggested that we allow for feedback during the presentation. If there are questions along the way, that we should take them. Given the complexity of the slides, folks may forget their thought and it could require some backtracking. So for everyone here, please feel free to weigh in with the hand raising or chat features during the presentations. And we hope that won't be too disruptive to our presenters. Thank you, and I'll yield to our executive director.
Yes, so I think you've said everything I wanted to say, David. So I will pass this on to Mary Jo. I want to, before she takes the virtual stage, I want to thank everyone who participated in the work group sessions over the last several weeks. I participated for part of the time in both of those, and the comments and thoughts that people had, I thought were valuable. I think some of that's going to be reflected in Mary Jo's presentation. So please go forward.
Yeah, I'm actually gonna cover the next couple slides. So we're gonna talk about the utilizing the framing questions. So the framing question responses help to inform the vision for our primary care in Maryland. And so we're in the process of developing an approach to track progress towards achieving that vision and moving to drafting the primary care investment definition that reflects that vision. So you're going to hear a lot more conversation tonight about the investment. So next slide, please. So what I'd like to do now is talk about the work of the primary care subgroup. So the subgroup met twice to review examples of how progress toward primary care operational elements could be measured and discuss possible approaches to measurement, data sources, and rationales. The workgroup members noted the importance of an evolutionary process that adjusts the measures and data sources to reflect growing availability of clinical and other data. The members recommended a set of priorities for measuring progress towards primary care goals. The priorities were based on the potential impact of the operational elements, the appropriateness of the measure to answer the question, and the availability of the data. A few measures were recommended as observational due to their potential for high impact, but lack of available data due to coding or other data constraints. So now I'm going to turn it over to Mary Jo, and she's going to walk us through the measuring progress towards primary care goals table.
Thank you, Melanie. So as that table is brought up, just want to echo the thanks to the subgroup members who provided just really exceptional input into this process. Subgroup members, as we walk through the table, please feel free to share your comments and thoughts as well, or stop me if you think I've misrepresented any of your input. What we're going to do today is sort of walk through this table and some of the progress that we've made since the last time this group met. And then we'll also close with a list of approaches that have been recommended by the subgroup as sort of our initial set, and review those with you as well. So you might remember there were some framing questions that were sent out to this group a while back that really sort of related to those 4 pillars of primary care. Those framing questions included different types of operational elements. And the purpose of this document and this work is really to think about how will we measure progress towards achieving those operational elements. So what I'd like to do is walk through the example of the approaches and the rationale for each of the priority approaches. Because several of the approaches will be used to measure progress towards multiple operational elements, you'll see some repeating, and we'll try to sort of minimize that as much as possible and move quickly through those duplicates. So if you go up a little bit, the first operational element was really to think about where care is, there we go, is to think about where care is delivered, what type of care setting is care delivered in. So for example, is it being delivered in an office, or is it being delivered virtually? One of the sort of key takeaways, I think, from our first subgroup meeting was that there are multiple ways to measure progress towards some of these operational elements, but we really wanted to focus, at least initially, on where we felt the data was the strongest and would offer the most impact. So for this one, initially we were thinking maybe measuring it via a survey question as well as through the APCD. The subgroup determined it would be most appropriate to start with the APCD and to sort of hold off on some of the survey methodologies until a future iteration, perhaps, of the measurement approach. So you'll see here, this would essentially be looking at the CPT codes, the taxonomy codes, and the place of service codes to define primary care. and then looking at the place of service codes and various modifiers to understand where that primary care service occurred. The next is a similar approach, but this one is going to be focused on the personnel who is involved. Another, I think, theme that we heard throughout the subgroup meetings was a real interest in better understanding team-based care. And again, this is a time, an instance where the data sources may evolve over time. But for now, using the taxonomy codes, which essentially represent a provider specialty, to understand who was the personnel involved in seeing that patient. We do have a sort of a, I'll say a notation here, or just a remembrance that while taxonomy codes do offer a high level of granularity, you're going to see some examples of that in a little bit. The claim does not always reflect the provider who actually rendered the service. All right, let's go on to the next one. So this referred to level of first contact, and essentially looking at the claims data to better understand when services were rendered by providers working for the same organization. We can see this in the claims by looking at the servicing and billing provider, although as noted here, a robust provider directory with organizational affiliation will allow for more accuracy in this over time. All right, let's go on to the next one. I think there might be one more down. Here we go. So this is looking at the scope of services offered by primary care providers. We know that some primary care providers perform minor procedures and other services that are not performed across all primary care providers. In this analysis, the analysts would show the distribution of services that are performed by providers with a primary care taxonomy, and could answer questions such as what percentage of primary care providers are performing certain services. And it can also provide insight into the percentage of providers' utilization or total bill dollars that are included in those services. If you go down one more, this is where we look at integrated behavioral health. So there's actually several measures related to integrated behavioral health. There's a set here that are looking at standardized quality measures. These would be combined with some other standardized quality measures that we'll talk about in just a few minutes. And then also we're going to have this next one, which is observational at this time. And this is really looking at the frequency of utilization of certain types of integrated behavioral health care. So looking at the use of the psychiatric collaborative care codes and other integrated behavioral health codes. There was some important discussion at the subgroup around whether or not to include these, as integrated behavioral health is growing in its use in Maryland. However, we know that sometimes these codes are not always well documented in billing. And so the group determined that as part of sort of an effort to demonstrate the need for integrated behavioral health and that as a priority, in just sort of seeing as we look at different primary care delivery trends across the country, wanting to include this, but include it as observational.
Mary Jo, could you define what you mean by observational?
Sure. So I think the goal here would be to measure this and to report it in a way that shows that we do not think that these results are necessarily representative of what's actually occurring in practices, but that we think that this is important to measure over time. And so we're working with providers and with payers to think about ways to improve the comprehensiveness of documentation of these services.
Thank you.
The next is another behavioral health measure, and this one is looking at utilization of certain behavioral health screenings. And then the next is the second observational measure, which is looking at rates of SDOH or social drivers of health screenings. And again, similar to the other, this was identified, social driver of health screenings was identified as a priority of the subgroup. That being said, there was an acknowledgement that this is sometimes being performed and not always coded. And so again, putting it forward as an observational measure so that we can measure change in it over time, demonstrate it as a priority, but recognize that the information that we're seeing may not be exactly representative of what's actually occurring in practices. The next is around readmission rates. And this is really to better understand the links between primary and secondary or tertiary level of care. And, obviously measuring rates of readmissions can help us in developing an understanding of how well providers and specialists and facilities are communicating with each other. You'll note in the next one, the rationale starts off with while imperfect. And I think that, we could probably say that honestly for just about all these measures, but really sort of thinking about what we can do now and how we can build over time. One of the things that we talked about at the subgroup is how far measurement has come and how it continues to evolve. So we do have, I think we already talked a little bit about the behavioral health quality measures and the utilization of psychiatric collaborative care codes and other integrated behavioral health codes. These are some of those examples where the same approach was able to measure progress towards multiple operational elements. I think overall we had about 29 operational elements. And at the end, you'll see that we'll have 10 approaches, some of which have multiple measures that will cover 20 of those operational elements to start with. All right, so let's go to the next. Yep. All right, so if you look there at the chronic condition quality measures and scroll over, there were several chronic condition quality measures that were highlighted by the group. And I'm going to look at my list here to read them off for you. Acute hospital utilization, emergency department utilization, as I mentioned, plan all cause readmissions, the controlling high blood pressure measure, the comprehensive diabetes care measure set, and then prevention quality indicators, which are often also referred to as measuring ambulatory care sensitive conditions or admissions for those. Those are conditions that, admissions for those conditions can be reduced over time with good access to primary care. And then follow-up after emergency department visit for mental illness and risk of continued opioid use. So those last two being the behavioral health quality measures. So let's go to the next one. And this is really sort of taking that same analysis that we talked about earlier and looking at it a little bit different way. So one of the operational elements is really priority that continuity is based on, care with the same care team. And so this would be looking at the percent of services delivered to individuals by providers within the same healthcare system or organization. Again, similar to the caution above, we can do this with the claims data that we have over time. Building out that provider directory to have more robust organizational affiliation may be helpful. And then as we go down, I think there's one more there on the advanced care planning codes. There we go. And so that last one, advanced care planning codes, this is really measuring the utilization of how often these services are occurring. So Ben, would it be helpful for me to sort of read through all of the approaches one last time for the group, or David?
Yeah, I think that'd be a good idea. Just before you leave advanced care planning, there's been some recent work done on the level of advanced care planning engaged in the Medicare population. I suspect among the privately insured, there's virtually none. Is that we're going to be looking forward to anticipate that that's going to grow. Or why specifically call that out on the private insured population?
Sure. So this was one of the operational elements that was defined by the group, and this was determined to be the best way to better understand progress towards that operational element.
Yeah, go ahead, Mary Jo.
Sure. So again, excuse me, I'm going to look at the list over here just so I make sure I don't miss any. So the first is to calculate the proportion of primary care services that are delivered in various care settings. So office, telehealth, et cetera. The next is to calculate the proportion of primary care services delivered by various clinician types. So physicians, nurse practitioners, physician assistants. The next is to calculate the proportion of primary care services delivered within the same care team. And then to calculate the scope of services provided by PCPs. So for example, the percent of PCPs that are performing minor procedures. The next is to calculate that list of nationally standardized quality measures that I reviewed previously. I'm just going to go through them again. Acute hospital utilization, emergency department utilization, plan all-cause readmission, the controlling high blood pressure measure, the comprehensive diabetes care measure set, the prevention quality indicators, or those ambulatory care sensitive admissions, and then the 2 behavioral health related measures: follow-up after emergency department visit for mental illness, and risk of continued opioid use. And all of those are nationally standardized NCQA HEDIS measures. And then there would be calculating utilization of behavioral health screenings and utilization of advanced care planning. And then those 2 observational measures, the first to calculate utilization of the psychiatric collaborative care codes and other integrated behavioral health codes. And then the second to calculate utilization of the SDOH screening codes. And that is the measure, the set of approaches that was recommended by the subgroup to begin its work measuring progress towards primary care goals.
And the integrated behavioral health treatments, they have a different code sequence than the independent behavioral health codes that would be rendered by an independent behavioral health specialist.
Well, it's tricky. So there are some codes that are sort of considered to be integrated behavioral health codes, but there's also a lot of times when behavioral health services are provided in a way that I would say is in collaboration with a primary care practice that would use just standard coding. And then you could do things such as look at the billing provider to see whether or not that organization is primary care, et cetera. So there's going to need to be probably a multifaceted approach to really understanding this. One of the discussions at the subgroup was also sort of how over time will we capture information on care such as integrated behavioral health that is being paid for outside the claim system. That could be through a third-party vendor or through a non-claims payment. And so I think the group wanted to get started and do what it could now, and then continue to work to think about other data sources that could supplement this and provide additional context. And members of the subgroup, please feel free to jump in and correct me there.
And then are you watching hands raised? I don't see anybody yet.
Yeah, there's no hand raised at the moment.
Yeah.
Right.
Mary Jo, do you want to continue?
Sure. I think that's all that we have for this topic. Oh, it looks like Dr. Bernstein does have his hand raised, Ben.
Go ahead, Dr. Bernstein.
I have a question. I'm almost embarrassed because I did participate in the subgroup. is this intended to measure overall programmatic progress and success? And or are these intended as measures of individual providers and practices within whatever program is created for distribution of resources or incentivization? And it's kind of a basic question. I'm sorry, I kind of missed the the boat on this.
So Mary Jo, do you want to tackle that? Oh, sorry, I didn't mean to.
I'll let Ben, Ben seems to,
So I think, I mean, if I understand your question, are we setting up this framework to measure individual practices versus is this really a definitional construct in which everyone counts, all primary care providers count, but we're not individually profiling how an individual practice would do. It's the latter, not the former, that we do not anticipate at this stage, this being used to benchmark, you know, how comprehensive your primary care practice is against a benchmark. This is an overall defining the aggregate spend utilization for what we would define as primary care providers overall. Does that help, Dr. Bernstein?
Yes, that exactly answers. That was my sense at the beginning, but you know, some of the when focused on some of the details and possibility, I think we sometimes are thinking in more narrow ways. But that exactly answers the question, and it correlates with my overall impression. Thanks.
Other questions?
Hi, Ben, this is Nora. Hey, Mary Jo. I was not able to make the last meeting, but one thing as you were going through all this that it reminded me of, I keep thinking of like the primary care physicians that we have that are doing behavioral health work. And there's something, I believe it's called MCCs. Like there's a Medicare, there's a way to group codes together to be able to look at things more broadly. And I've done other analyses in the past where it's really helpful for something like this, so that if we're trying to capture broadly what services are being delivered, irrespective of the type of provider that's doing it. So that may be one source to use. I believe they're called MCCs. I'll have to look it up. I'm forgetting what it's called, but it's really useful.
yes, so there is something called MCCs, or at least what I think of as
Are
MCCs,
you
but
saying MDCs or MCCs?
MCCs.
Okay, I'm thinking of major diagnostic categories, which is
No, oh, go ahead, Mary Jo.
no, go ahead, Nora.
It's a way that they take all the billable codes and they group them by different groups and say like a big group is behavioral health. I'm exaggerating just to kind of explain it, but it's used in a lot of research with big data, and it can be helpful when we're trying to kind of look at this more broadly and see where things fit and what's really being delivered.
So Nora, I think that's a great point. And what I would probably mention is later on in our conversation today, we're going to be talking about various ways to define and measure primary care spending. And one of the things that I think will be that the state may want to look into as it does that work is, in addition to sort of measuring spending as a whole, breaking out the definition into sort of chunks or categories so that you could see, oh, here's how spending on office visits has changed over time, et cetera. And you could do that with a wide variety of categories. So I love where you're going, Nora. And I think, we can think more about all the different ways to share information on primary care spending and progress towards these goals over time.
Great. Thank you, Mary Jo.
So I wanted to go back to a point again on comprehensiveness, and your experience in other states may be enlightening. And then I'll ask a couple of the work group members to comment too. This exercise involves primary care in all sorts of environments. Commissioner Buzinski remarked, one of our primary care commissioners remarked that what he delivered as primary care in Garrett County was considerably broader than what a primary care physician in the Baltimore or Washington suburbs would define as primary care. And he referenced delivering babies, reduction of fractures. How have other states really dealt with that? Because certainly some of our colleagues in other states are much more rural than Maryland is, but the scope or the comprehensiveness of primary care is somewhat shaped by the overall practice environment in which you operate.
Absolutely. So it really depends on the state on how they have tackled that. So for example, states including Colorado and Oregon tend to have broader definitions of primary care than states such as Utah and Rhode Island. And the reasons for that are complex. I will say that those states, so Colorado and Oregon, that both do include those delivery services in their primary care definition, they do actually reduce it to 60% of the total charge, just to sort of think about what is the primary care component of that delivery bundle. So that's just one other thing to keep in mind. In terms of the procedures and the setting of the bones and all of those other things, I'll tell you that definitions also change over time. So initially, the state of Delaware decided to not include some of those things in its definition, and then over time decided to add them, and simply just published retrospective data using the previous definition and the new definition, so stakeholders could see the impact of those changes in definition. If you look at some of the national sources, so for example, the original Milbank report and then the more recent NASESCO report, both of those sort of take a dual approach in having a narrow definition that includes a more limited set of services provided by primary care providers, as well as a broader definition that includes essentially all services provided by clinicians with a taxonomy code or a specialty that is determined to be primary care. So it's not as though everyone else has made the same determination. There's a lot of different flavors of definitions, but it's typically, driven by stakeholders. One thing I will say is that, the addition of those maternity services tends to add about 0.5% to 1%, depending on the payer type. The addition of the many other procedures and some behavioral health codes in Delaware added about 1 to 1.5% to the spend as a percentage of total medical expense. So it doesn't often, no one decision in the numerator tends to make a really dramatic change, but obviously as decisions add up, you do see some difference based on the definition that is used.
Thank you. Thank you. Any comments? Dr. Cheatham, I bet you thought I was going to ask you. I have a little bit of a variant of this question based on the type of delivery system different providers are in. I mean, is this definition of primary care consistent with what you at Kaiser would think of, or is there a need to broaden or narrow that definition?
We're pretty much on the same definition as primary care, so pretty consistent.
And we'll come back for a couple questions when Ken starts his, but thank you. Others that are in more managed environments have any thoughts on this? And assuming some people haven't read all the literature, Mary Jo, what does that say? What do we see nationally in terms of the share of total spend dedicated to primary care? In, I don't think we can say completely open systems, but as we move from more tightly managed to less tightly managed delivery systems, what can you say about that?
Sure. So I think as we look across markets, the share of investment that is dedicated to primary care does tend to be higher in states where we have, I'll say, more integrated systems. So for example, Colorado and, well, actually, for example, I'll say Oregon. As you look through the data by not only payer type, but also by payer, you do have higher percentages of primary care spend in those systems than you would in let's say a state like Utah, or where you would have less of that. The other thing I would mention is that across the country we see primary care spending that might range from around 5% or less, all the way up to 12% across the state. There are payers in Oregon, I know, who have close to a quarter of spend that is deemed to be primary care. I believe those are Medicaid managed care organizations that likely have a smaller denominator because they might have a lot of kids enrolled in those plans. So you're looking at market type, the care delivery system type, the age distribution of the individuals. There's a lot of factors that play into what is that primary care percentage.
Thank you. Other comments? Are we passing this back to Melanie now, or are you still on stage, Mary Jo?
So I think we have a couple of slides we're going to go to. Is that right, Melanie?
Yeah, so we're going to go, and Mary Jo is going to kind of give us an overview of some of the ways different, some of the components of primary care definitions and how that plays into the primary care investment.
Thank you.
All right.
You
Can we
can
dive in, Ben?
Yeah, go ahead.
Okay, so this slide provides you just sort of an overview of the equation used to measure primary care investment or spending. You'll see that there's a numerator and there's a denominator. And at the end of the day, what you end up with is the percent of primary care spend as a percent of the total cost of care. So in the numerator, you'll see claims-based payment for primary care. So those are, when a CPT code is used to describe a service and a provider submits a claim and is paid for that service. And then you also see there non-claims-based payments for primary care. And you'll see that we've put those in sort of dots to note that not all primary care spending definitions include non-claims payments for primary care. So it's not a requirement, but a growing number of states are including those non-claims based payments. So what do I mean by non-claims based payments? Well, that could include an incentive payment for performance on a set of nationally standardized quality measures. That could include a per member per month care management or care coordination payment. That could also include a portion of a risk settlement or shared savings payment. So there's lots of different flavors of non-claims payments, some of which are considered primary care, some of which typically are not. And when you add the claims-based payments and the non-claims-based payments together, you get the total primary care spend. Down there in the denominator, you'll see total claims-based payments. Now, this in some states includes both medical and pharmacy. In other states only includes medical. So there's a question in the chat, does non-claims payments equal cash? Well, it's really just a payment outside the claim system. So for example, let's say that I'm a payer and I want provider organizations to do more care management or care coordination. I want to make sure that my members are with chronic conditions are being well managed. And so I may say to my providers, okay, I'm going to give you an extra $5 for every member of mine that you have that's attributed to you or that's in your panel of patients. I'm going to give you $5 each month. And in exchange for that $5, I want you to make sure that their chronic conditions are managed. So that's an example of a non-claims payment.
How about an example that means a patient pays the provider cash? That's what I meant by that.
I see.
Yeah.
So those payments are typically not included in these measurements because they're simply not collected by the data sources that are typically used to measure primary care spending.
So just to elaborate, John, are you talking about a person that's uninsured that pays out of pocket or an insured patient that pays co-pays and deductibles?
I guess it's on my mind, Ben, because in behavioral health, we're finding lots of folks who cannot find a provider or providers who will not join the network. And there's this huge group of people that are just paying cash because that's what they have to do to get care. That's what made me think of it.
In that case, yeah, that would be characterized as out of network, and we'd have to think hard about how we captured that information.
Well, it doesn't sound practical to be captured, but it certainly is a non-claims based payment.
Yeah, it may
And
Go ahead.
this is Sally. Sally, so would that be classified as out of network or just simply another payment type?
for an insured person, I would classify that as out of network.
Okay, so then we'd have to distinguish between insured and uninsured.
But yeah, I think the example that John
Because
raised.
we have a lot of uninsured patients
Mhm.
who pay cash or check, whatever.
Right, and I would put that in a slightly different bucket. Both of those are challenges, but for characterizing spending by the uninsured, we probably do have some data sources, the MEPS, for example, that we could, to lack of a better term, fill in spending by the uninsured. For the out of network, it may be that the medical expenditure survey would be something we'd have to look at as well, but I would put those in two separate buckets of spending from the standpoint of measurement. I think, obviously, if you're the level of risk that one has that's uninsured is greater than if you're going out of network for behavioral health services. Not to say that that's not troublesome and expensive, but I would characterize it as somewhat different.
Well, I guess
Thank you.
I'm sorry, Ben, for beating this dead horse, but we're not even talking about someone who's uninsured here. This is a person that's insured that simply can't get a provider to see them and must pay cash to someone in order to get care. So for what that's worth.
This is a problem that states are facing as they look to measure spending on behavioral health investment. I can tell you that the state of Massachusetts has a annual survey that it does of residents to try to understand exactly the type of spending and the amount of spending that John Miller is referring to. So we can, think about some other ways to collect that data. It is typically collected via survey, whether that's through MAPS or through a state survey.
Yeah, the point that you're raising, John, is a good one, but it may be that we have to probably put that on the whiteboard for thinking about, as we move through the sort of building out the framework, and then we have to deal with the leakages, which is things we can't collect.
Yeah, understood. It's an exception. So thanks.
Yeah.
Dan, I wanted to note that Dr. DeGarala and Dr. Bernstein have their hands up.
Dr. DeGuala, please proceed.
Thank you. I had two questions about the non-claims-based payments. One is regarding HART payments that are part of MDPCP, because those, even though they're going to the primary care providers, those payments are meant for social service payments. So they're not, I'm just wondering where that would be included. Would that be included as payments from primary care? Or would that be considered excluded because they're actually going not specifically to primary care services, but more to social services? The second question I had is about shared savings. I'm in an ACO, so when we get shared savings payments, not that entire shared savings payment is made to the physicians. Part of it is given to the ACO depending on how their contract is set up. So how do we acknowledge that some of that's going to the overhead of the ACO rather than to the primary care physicians?
Sure. I'm going to take the second one first, and then I'll go back to the first one if that works for you. So with regard to the second one, it's clear that not all shared savings payments are spent on primary care, right? So we know that they may be spent on a wide variety of expenses. You may be a health system led ACO that needs a new MRI machine. And so when you get a shared savings payment, you buy one. And that's a business decision. It's not a value judgment. It's just not primary care. And so one of the things that we've helped some other states do is think about what will be their approach to classifying risk-based payments as primary care versus non-primary care. So working on this in a couple of states now, I can tell you it's not super simple, but it can be done. The approach, for example, that is being used in Delaware right now is to basically say that, if you want to, whatever you're spending on primary care in total, if you want to say that the same proportion of your risk-based settlement, like let's say it's 8.5%, was for primary care, that's fine. So if you want to put 8.5% of your risk-based payment towards primary care, you can do that. You can say that that's primary care investment. But anything more than that, the state is requiring a detailed attestation from the provider organization talking about what they spent the money on. In Massachusetts, there's another approach that sort of just asks more questions about sort of how the dollars were used. In Rhode Island, there's a provider survey and a payer survey. So every state has a different approach. But I think there's general agreement that you're absolutely right. You can't just say all risk-based payments, well, that's primary care investment. That's just not how it works. With regard to your second question on the HART payment, there's a lot of different types of payments that can be considered non-claims-based payments for primary care. We see states that include payments to support community health workers, payments used to support a wide range of medical and social services. It's really up to that state to consider what makes sense based on the different payment mechanisms there.
So before we go on, I thought I would ask Tyler Blanchard to comment. Tyler's from Aladade. Do you have a perspective? Tyler may be on mute.
And it looks like he may have dropped off,
Yeah, that's what I was gonna say, David.
but
I don't
yeah,
see,
Dr.
I don't see him any longer either.
Dr. Bernstein.
Yeah, I think what I was going to add is I think that that's really for this work group to work out. I think the broadened definition of what primary care providers are expected to do does make me think that it does get included in the numerator, but that's something I think over the course of the next 6 to 9 months, we'll want to reach a recommendation on. Key to the point raised about heart payments that at the present time is a payment that goes to a Medicare model, although how that's actually distributed, I recognize there could be some differential approaches that practices are doing, but I think it's a good question as we broaden out the role of primary care even further. Dr. Bernstein.
I don't want to delay or belabor, but I do want to emphasize Mr. Miller's point. I think that expenditures by individuals and other societal entities for non-covered or non-participating providers and services, even among the insured, is likely significant. I don't think it's necessarily trivial, because if there are services and spend by other societal elements that could be eventually spent within the primary care structures, that should be counted or at least estimated in some way. I don't think it's necessarily trivial. Just emphasizing Mr. Miller's point.
Thank you. And there was a chat question we missed a moment ago, which is to Dr. Bernstein's question. I assume that we do an overall estimate for the state, but break out by Medicaid, Medicare, Medicaid, and the commercial market. That's correct. I'm not sure if the overall share is going to be that meaningful as we compare ourselves to other states, but I think that would be the objective. But I think there's recognition that if we did set benchmarks for primary care spending, they would have to be certainly at least considered as potentially different from Medicaid and the commercial market. Obviously, we have less control over what Medicare is doing, but I think we can see strong momentum for Medicare as well, nationally setting spending levels for primary care. So we may not be able to set that ourselves. We may be able to offer recommendations, but I think their thinking is much the same as many of the leading edge states. Mary Jo, do you want to continue?
Sure. So I think what we may want to do is go ahead to the next slide. And so as you're thinking about that numerator, particularly the claims-based component of the numerator, we wanted to sort of show you what are considered to be some of the most common and less common decisions made by states. So the first is to say that numerator of claims-based payments, if you think of that first box in the left-hand corner, is typically defined as a set of primary care providers as defined by their taxonomy code. So the taxonomy code is an alphanumeric code. It's nationally standardized, and that alphanumeric code says what type of specialty or subspecialty the provider has, the clinician brings. And then primary care service, which is typically defined as a CPT code, and then primary care place of service. So there's also place of service codes on claims, professional claims at least, that tell us where the service occurred. So you'll see there under the provider specialties, most common provider specialties include, and these are providers most commonly included as primary care, in state and national definitions of primary care spending. So we have family medicine providers, general practice clinicians, internal medicine, pediatrics, nurse practitioners, and physician's assistants, typically only those who have a more general classification or taxonomy, the same as internal medicine and pediatrics. So it's not going to be every internal medicine provider, not every pediatrician, but those that have more of those primary care taxonomies. Geriatricians, and then FQHCs and rural health centers. And then less common, we have various types of nurse taxonomies, OBGYN taxonomies, and behavioral health clinician taxonomies. As you're going to see in just a few minutes, there are many taxonomies that are available. So while we say here sort of generally internal medicine, what you'll see in a few minutes is sort of, you know, a more discrete list of what those are. So again, not going to be every internal medicine taxonomy, but those really focused on primary care. Same for pediatrics, same for nurse practitioner and physician assistant. In terms of the services, most commonly we see office visits, preventive visits, the vaccine administration, not actually the cost of what's in the vial, since that's not really primary care spending, it's just more of a pass through the primary care office. Care coordination and management, and then preventive health and other screenings, behavioral health screenings, for example, SDOH screenings. Less common, we see procedures, behavioral health services, so like therapy or other outpatient behavioral health services, and maternity care. And then in terms of the place of service, what we see most commonly is office visit or the office setting, telehealth setting, the walk-in retail clinic, again, FQHCs and rural health centers and home. But we do see some states include worksite, urgent care, and schools.
Questions? So, Mary Jo, before we leave this, I know that Dr. Marsteller had a couple questions earlier. They related to uncompensated care and pro bono care. Given that, you know, the goal for this is to set a share of insurer payments that are devoted to primary care. But in that context, is any state tackling this pro bono uncompensated care issue directly?
Not for this purpose of sort of better understanding primary care spending. I think, you know, there's two sort of use cases for measuring primary care spending. One use case is to understand all the dollars going to support primary care in your state. And another use case is to understand whether or not core primary care services are adequately funded. And although those sound like the same use cases, they're actually a little bit different. And they sort of influence the measurement decisions and the definition decisions you make. So if you're trying to understand, well, what are we spending in totality on primary care services? Typically that leads to a broader definition of primary care. And that could lend itself to sort of, you know, tracking down some of these offshoots or other layers of investment that may be occurring. Most states, though, are really focused on understanding our core primary care service sort of adequately funded, or do we need more spending there? And so they're sort of willing to make do with understanding or measuring the large categories of spending, and don't honestly I focus as much on some of these others.
Dr. Marsteller, do you have any comments?
Yeah, just that, you know, if a practice is doing a lot of charity care or they're not getting full payments from people who don't have insurance, then that goes to the point of whether or not primary care services are supported adequately, because there has to be some cost shifting essentially. So, as any given portion of practices patients can or can't pay, they would be in a pickle in terms of covering the costs of the people who can't pay. And so, I think that it's a really good point. I think bottom line, we probably don't have a source for that information consistently across all of the sites. But, I think it's an important consideration. Sliding scale clinics and other ones like that, they end up having to cover, and they're happy to do it, I know, but they end up essentially losing money on some of their patients. So I think it's something that would be wise for us to try to figure out.
And someone else added in the chat that we should also consider concierge.
Right, that's the other end of,
Which
yeah.
is at the other end of the spectrum in terms of people who are opting out of using an in-network provider. I don't, Dr. Barr, do you have any comments?
Yeah, I just really like Mary Jo's comments about the two different use cases. I think we have to keep reminding ourselves, what are we trying to achieve through this exercise? So I think that was framed very well, Mary Jo. Because there are going to be all these little pieces, including the concierge one I mentioned, that might add up. It might be an indication of how, well, depending on your perspective, how good or bad the system is, right? I have my bias, but it could, the more concierge money being spent might be an indication of poor access for those, or might just folks like quality issues. They feel like getting better quality. So, but that may not be the exercise, Mary Jo. So I think your point is well taken.
Go ahead, Mary Jo.
Sure. So there's also one other question in the chat, I believe, on taxonomy. For taxonomy claims, or taxonomy claims for taxonomy, are claims always reported to the highest level of specialization for the provider? Does it vary based on the service on a claim? It does not vary based on the service provided on the claim. And that's why, clinicians have a taxonomy. They register that taxonomy with NPES, which is sort of the national keeper of taxonomy codes. And they also share that taxonomy code with the payers that they contract with. And then that taxonomy code, in an ideal world, follows them all over. I will say that some clinicians have multiple taxonomy codes. So for example, let's say that you're an internal medicine physician, you become board certified in internal medicine, and then you say, wow, I'm fascinated by gastroenterology. I want to become board certified in gastroenterology. And so now you have two taxonomies. You have your primary care, or your sort of general internal medicine taxonomy, and then you have your gastroenterology taxonomy. And that's where it can get a little bit tricky in sort of determining and having a methodology to determine what is the most appropriate taxonomy for that provider based on their current sort of scope of services that they're providing. That may have been a little too in the weeds, but.
Okay, I think we've gotten the questions whittled down. Go ahead.
All right, let's go to the next one, and then we'll wrap up here. And I do see a couple of other questions going in the chat, but we can grab those in a second. The last piece is just on the denominator. So there's a couple of important questions here. The first is around retail pharmacy. So states are sort of split as to whether or not to include pharmacy in the denominator. I want to make a couple of points about sort of why they tend not to in many cases, although in some states they do. So states that include pharmacy in the denominator typically do so because that's how other definitions of total cost of care in the state are currently framed. So for example, states that have a total cost of care benchmark and want to measure to that, they often include pharmacy in the denominator because that's how their other total cost of care measurement happens. It's important to note, though, that pharmacy spending is typically inflated because the data is coming from an APCD, often, not always, but often, and that does not deduct rebates. They don't have access to the rebate information. And so that can make that pharmacy spend, you might say, higher than it is sort of in reality because it doesn't net out those rebates. From some perspectives, those who want to see a higher investment target, that can be good. If you have a higher denominator, you have sort of a better chance of increasing investment to reach a benchmark or a target. But it also generates pushback from folks who sort of see that denominator then as inflated. The other piece is around differing services across payer types. So, for example, the types of services that are covered under a Medicaid plan can be really different than the types of services that are covered under a commercial plan. Payer types also differ in their population. So some Medicaid plans, for example, have a lot of kids, and that brings down their total cost of care just because kids thankfully don't need as many services. Medicare often has a high total cost of care because their folks are older, and they need more services. So these are just certain things to keep in mind as you think about if you do want to one day think about a benchmark, would you want to have one benchmark or multiple? And then just also as you think about the results, understanding results by payer type. So one thing to consider is how you sort of develop a standardized basket of covered services so that you can compare across those different payer types as best as possible. All right, then I think that's all that we had on the slides.
Okay. I'm going to call on one of the payers to comment on what, in terms of what you heard, any thoughts on, before we actually get into some of the algorithms, any thoughts from payers on whether pharmacy should be included in the denominator or not? Let's see who I can put on, call. Kathleen, any thoughts?
So good evening. Thank you, Ben. I was thinking about what was made with the comment that was made, and I think, at least for the Medicaid program, pharmacy is even trickier because not all drugs are covered by the payer. Some are covered by Medicaid program. Some are covered by an MCO. And I think, the comment that was made about looking at total cost of care by programs because of the differences in need and also in benefit design is really true. So it's hard for me to comment just generically whether or not pharmacy should be included. I'd want to look at Medicaid specific and probably think more about how it works in the Medicaid program today, because not all drugs, like I said, are covered by a payer who's an MCO. Some drugs are covered under the fee-for-service program still.
Thank you. Now we have about 20 minutes left, and we're going to look at some of the formulations on how other states have calculated primary care. I see that Ken Yates-Trotman will present, but I also want to note that his colleague Ose Masalu worked extensively on this presentation. It was a great team effort, and this puts some flesh on the bone of what we've been talking about over the last hour. We actually have a limited set of statistics to show you. As you're going through this, we're not going to poll people today, but as we conclude, anybody who wants to offer impressions is welcome to do so. But also, as we proceed into the work into March, think of additional information that you might need as we build out this definition of how we'll define and measure primary care. So Ken, the stage is yours.
Thank you, Ben. Good evening, everyone. My name is Kenneth Stratman. I'm going to go through some of these measures for the primary care investment using the MCDB and see what other states are doing. Next slide, please. So first, I'll talk about the study population that was used for this analysis, and then go through the measures using the Milbank plan narrow definition, and then see what the Maryland primary care results using the NESCO definition, and also the Colorado definition, and then finally the Robert Graham Center definition. Next slide, please. So the population that have been used in this study is the Maryland residents. These are privately insured members who were enrolled in privately insured health plans with no age restriction. Also, the market segments that are included is the individual market and the small group market. These are fully insured, of course. And then we have the large group market, which is composed of the fully insured large group and then the self-insured non-ERISA plans, including the state employees and local government as well. So the information that is excluded from the study, not by choice, but things beyond our control, is the self-insured ERISA plans. These are the large employer groups, and also the federal employee health plans. This information not included due to federal decisions. The Kaiser data, we don't have that as yet. Lack of allowed amounts, especially on the professional services side, so we're not able to include Kaiser. And of course, as I said, this is a privately insured study, so Medicaid and Medicare is not included. Next slide, please.
Yeah, if I can interrupt. So we are working with Kaiser. We eventually think we're going to solve this challenge. Medicare and Medicaid, we will be doing independently and separately in the future. The hard stop is on self-insured private employers. And to almost the same degree, the federal employee health plan data, which because of federal decisions and federal law, we can't access currently. We're hopeful for the future, but there's no easy solution to that. So back to you, Ken.
All right, next slide, please. So the first result we're going to look at is the Milbank. We call this the narrow definition, and this includes 9 categories of taxonomy or specialty definitions, from the family medicine, general internal medicine, all the way down to the nurse non-practitioner. Next slide, please. Next slide, please.
Yeah, we got it.
Thank you. So, so this slide demonstrates the primary care as a percentage of medical spend on the left-hand side. So we see for Maryland, Maryland is about just under 7% for 2019 and about 6% for 2020 and 2021. The Milbank measure, we don't have the Milbank measure for medical only, so that's why we have a not applicable here. And for the primary care, these are providers who will have to provide services that are considered to be primary care in this definition. On the right-hand side, and this is the only example that we will have, we show the primary care spends as a percentage of medical and pharmacy. We have the Maryland at 5.5 and about 5% for both 2020 and 2021. And the Millbank, since they only show this this measure, including included here just for completeness. So 2019 is about 6%, and 2020 is just at 5.6. I must note here that at the Millbank method here on the side, all providers who are considered to be primary care based on the taxonomy code, but rendering any service. This is the Millbank measure here for the 6.0 and the 5.6. Next slide, please.
Yeah, I think, and the point, I think, just for the work group, this is kind of the granddaddy definition of a primary care spend, the one that was developed pre-pandemic, and the one that I think the staff internally is most familiar with because we've done it for a number of years. Is that correct, Ken?
That's correct, yes.
Okay. Go ahead.
Next slide, please. All right, so we're moving on to the New England States Consortium Systems Organization. And what this definition shows is that for everything that have included on the Millbank narrow plus these 9 categories, except for the homeopathic and physician preventive medicine, those are the ones that are included in the Millbank, but not in the ISCO definition. So we have in addition to the Millbank definition, we have these added taxonomy codes of specialties. We have the geriatric medicine and internal medicine, family medicine, which includes the adolescent medicine, adult geriatric, and hospice palliative. And then we have the internal medicine for adolescent and the hospice and palliative care. Maybe pediatrics, nurse practitioner, and the clinical nurse specialist, all the way down to the rural hospital. Next slide, please. So based on the NESCO definition, we look at see, well, in the MCDB, based on that definition, to see, well, what Maryland looks like. So that's why I say for Maryland NESCO, we see the primary care investment is about 9.9%, just under 10% for 2019, but 9.6 for 2020, and about 8.6 for 2021. And we continue to compare the Maryland Millbank, talked about in the prior slide. And this is as a percentage of medical only at 6.7, 6.2, and 6.0. Right, please.
And that does not include on the denominator pharmacy.
No pharmacy. This is for medical spending only. That's correct.
Mary Jo, since you've worked with some of the NESCO states, how does Maryland's figures compare to what we see in Massachusetts, Vermont, et cetera? Do you have those numbers off the top of your head? If not,
Yeah, you know what? I was actually just pulling them up. So if you want to just circle back to me in just a second, I will have them ready for you.
Okay. Questions on this? One question when I saw this is why? What do we think we're picking up here to make this share so much bigger? Ken, do you have any reasons?
For this analysis, this is for the taxonomy codes that are defined as primary care providers. The services that they provide don't have to be primary care here, for this particular analysis. So it's a wide amount of services. You just have to be a primary care provider based on your taxonomy specialty.
So I just pulled up that part of the report and looking at the commercial spending, and this was going to be for 2018, so it would be a little bit behind that 2019 number, although things look, relatively consistent across the 3 years. The average for this definition, which I just want to confirm, this is the all services definition, right? So was 9.3% across the NSESCO states, and ranged from 7.4% on the low end to about 11% on the high end. So sort of right at the middle is what we're seeing here across those states for this definition.
Thank you, Ken.
Next slide, please. All right, so now we're looking at the Colorado definition. This is a wide definition, both in the number of taxonomy, which is about 89 of them, and the CPT codes, which is about over 360 of them. So again, we these 9 extra specialties is in addition to what is included in the Milbank. The Milbank, we call it the Milbank narrow definition, except for the homeopathic medicine. So here we have of course we have the family medicine, which is adolescent, adult, and obesity and sports medicine, all the way down to the physician OBGYN, and also the physician assistants and advanced practice nursing providers and midwife. Next slide, please. Slide, please. So it was about 18 categories of taxonomy, that in addition to the Milbank narrow section. So for these results, these results are looking at the Colorado definition and how Maryland actually look. So for Maryland, Colorado, it's about 9.9%. For 2020 and 2019, and about 10.6 for 2021. However, for Colorado, what Colorado have reported in their state based on this method is at 6.0 for 2019, was 6.0 for 2020, and just below 6% for the 2021. And again, we compare this to the Maryland Milbank that we talk about a couple slides back. Now, as I said before, that the Colorado definition is about 87 taxonomy codes, and also about over 360 CPT as well.
So it's safe to say this is the broadest definition.
Yes.
And what jumps to mind is Maryland looks to be about almost twice as much as spending in Colorado. Especially if we look at the 2021 results, 10.6% versus 5.6%. Mary Jo, do you have any thoughts on that?
No, that's not a good answer. I deferred to Ken and the team, but I'm thinking I've worked with Ken long enough to know Ken's probably thinking, well, I'm going to go back and look at this again and, just keep thinking through it. I think I think it may be that there's some quirk in the data, or it may be that there's spending of 10.6%.
Oh, this is very similar to the slide before we saw with the New England states. They're about the same for 2019. There we go, for 2019 and 2020, and a little bit lower for the 2021 at 8.6 versus 10.6. And it's this for this one, the services that are rendered don't have to be primary care services, but just based on the
Primary care provider
specialty.
So Ken, that's a good point. So this is not all services, but a very broad list of CPT.
Very, very broad.
It's
right?
very broad, yes.
Very, very, very broad. So it's close to that
Sort of all.
If you consider to be all the services, regardless of the service rendered based on the definition for the primary care, physicians or providers, but I think that is the closest as far as broadness is concerned.
Mm-hmm.
Okay. Do you have one more slide?
Next slide, please. And then we move on to
this kind of brings back everything to where we started, right?
Right. So so looking at the this is of course the Milbank narrow definition that we talked about before. Next slide, please. And then we look at one more is the Robert Graham Center narrow definition. There's just a handful of taxonomy codes here. Family medicine, internal medicine, general practice, pediatrics, and geriatrics. Next slide, please. So based on the Robert Graham Center, we see it as the narrow definition. We see that Maryland is at 8.1 for 2019, and about 7.5 for 2020, and just above 7% for 2021. And of course, we compare that back to the Maryland Milbank that we talk about 3 slides ahead. Next slide, please. So with this one, we're looking at Oregon, and we don't have any measures, but we just look at the definition here, which of course includes Milbank. It includes all of the taxonomy codes, plus these that are displayed here as well. Next slide, please. So as Ben said, this is something that to think about, maybe for next time to choose, as we look over the slides and study them and think about them, and we maybe come back and see which one of these definitions would be suited for Maryland.
I guess we also want to leave open the Robert Graham Center implementation, which I think has caught people's attention, currently, because they are the ones who've come out with a dashboard recently. Before I throw it open, what's Delaware thinking of using? I mean, proximity is a consideration because practice patterns, delivery models tend to be more similar in adjacent or neighboring or close by states. Curious, I know you're working in Delaware. Give us any insight, Mary Jo?
Sure. So it's essentially a narrow definition, except that many minor procedures are included now. So over the last few years, that definition has evolved a little bit more behavioral health and a little bit some additional minor procedures. It does not include any maternity And the behavioral health services that it includes are very sort of primary care focused. It doesn't include, some of the behavioral health services that are included in like a Colorado definition, for example.
Thanks. Comments from the work group.
Then Laura Russell had a comment.
Nora, go ahead. Nora, Laura, oh, excuse me, I thought you said Nora.
Sorry,
Laura.
my only comment was there an option to include our own Maryland specific definition? Perhaps there might be elements of each of these definitions that we want to think about.
I think that's an option. I think starting out, I think the work group should balance out, narrow or broad. If I saw something like 10% spent on primary care, I might kind of say, well, it looks like we're ahead of other states. Maybe is not, not quite as aggressive approach would be warranted, given if I saw 6% or 6%, for example. So I think we possibly can do that. We're not going to try to decide that today, but we want you to be thinking about that as we move towards the meeting on March 13th. And, if there's other things you think you need, within reason, I guess I would say, that can be done in a couple weeks, that would be something we try to meet. But the short answer is yes.
And then Jill has her hand up, Dr. Marcella.
Yeah, I
ahead.
guess I just wanted to sort of throw this out. I think there are reasons why it makes sense for us to use another definition, because especially for comparability to other states and so on, it'll make it easier to see where we are relative to other states. It might make more sense to compare ourselves to states that are about the same size, or that, have some other similarities with us. That might be another thought. But I did want to throw out the idea that I think we should figure out what we think is the right definition kind of first, and then use it as, rather than, now that we know how we look on each of the different definitions, it's going to be hard to kind of avoid picking a definition based on, which ones we kind of look better with, depending, of course, on whether we want to be higher or in our percent spending on primary care or lower. So I just wanted to throw that out there, that I think maybe a process or a path forward would be to decide what we think is the right definition, and then use that kind of, rather than thinking about it in terms of how much or how we're doing on the different definitions. But I'd of course be interested in what other people have to say about that.
And then Kathleen Logan has her hand up.
Kathleen, go ahead.
Thank you again. And, I don't disagree with Laura or Jill's comments. I think we have to think about what is unique to Maryland in your attempt to choose a primary care definition. You need to look at what services are currently being provided and where they are, and how will your definition drive the availability of those services, particularly in certain geographic areas of the state. How many providers do we have that currently provide primary care? And that may depend in part on how you define primary care. I noticed, I think it was in the Colorado definition, I didn't see anything specific to geriatric. So I would look to see whether or not that would be included, because our population is aging, and I think we have to take into consideration what are going to be the needs of the population over the next 2 to 3 years, 5 to 7 years, 10 years, right? Because the need for primary care is going to shift a little bit based on the population. So all of those things are necessary in trying to define what suits Maryland's market best. And then again, trying to decide whether you start with a definition that's not only narrow, but applicable only to one marketplace. and then building on that as you gain experience.
Thanks, Kathleen. Any other comments? I see William Henderson from HSCRC has been listening along quietly. Given you're in the global budget business, I thought I'd ask you if you had a reaction right now.
No, I don't have a reaction right now. I would be interested in potentially running the same test on the Medicare data just to see how the different definitions work out in Medicare and differ from what, and compared to what we have been using on Medicare. So, but I don't know that I have a strong feeling in terms of anything else.
I think generally they're going to be a couple percent lower. Is that right, Ken or Ose?
Should be.
But
yes,
the other idea that I think we're probably have to look at in terms of version 2 of this is really looking at counting the prescription drug data if it's prescribed by a primary care physician as being in the numerator, and then all drug spending being in the denominator. That if we're going to use drugs, which I think is going to be challenging initially, particularly potentially in the Medicaid market, that's the way to roll in an area of drugs of healthcare spending that's growing pretty rapidly. Continues.
Yeah, Ben, this is Kathleen again. Keep in mind, you do have specialty drug that's not included in primary care necessarily.
Absolutely, yeah.
And Catherine, just for your information, I did locate on the Colorado primary care provider taxonomies, the specialty of geriatric internal medicine.
You know what? I saw that after you put it up. I didn't see it my first read through, but I did see it on the second. Thank you.
Sure.
Okay, we are at time. We are actually over time. David, I'm going to pass it back to you. I know we have a meet. I've warned them that we're going to have a meeting on the 13th. What else is on tab over the next 2 weeks?
So I think as our ED mentioned, our chair of this work group, we have some homework assignments to do on the staff end, and we'll get started on them expeditiously. We do have on a calendar a hold date for the Friday the 3rd. Since there wasn't any tasks that were delegated to a subgroup at this meeting, we will send out a notification to withdraw that meeting, and we'll plan to assemble on the 3rd, and we'll be providing some information between now and then. If I could invite my colleague Melanie Cavalier to talk about the closing aspects, we can then turn it over to the executive director for dismissal.
Yeah, and so David meant the 13th, that's what he meant what we'll do following the meeting is we always post the recording and we post a very brief meeting summary. So people are always welcome to reach out to staff if they have any questions. I think that's it for now, David.
And just to clarify, the calendar hold on Friday the 3rd is for the primary care subgroup, and so
right, and then 13th. Oh, sorry, the 13th is for the full group.
Yes. Okay, so we'll turn it back to the executive director.
So I have one more question for Mary Jo, and that is, of the dozen or so states that are considering definitions, I don't think we can say a majority have chosen any definition, but the modal definition is what? Can you?
The modal definition is NACESCO right now, although that could change with the Robert Graham Center. That's very new, so that could change. But right now, the modal definition is NACESCO. That being said, just to complicate things even more, Some states measure using the NASESCO definition and their own homegrown definition so that they can compare to other states, but also use a different definition for internal benchmarking purposes.
Yeah, and I think that was the point I'm making here, is that, you know, we aren't necessarily limited to one, and we might want to have, you know, I think there is value in benchmarking us to other states, but in terms of operationally, something that might be applied to insurers, it could be potentially something different. So a lot to think about in terms of formulas. I think we probably want to send out a little bit more detail for those who really want to get down into to the taxonomy codes and the CPT codes, just to see what's meant, how they're constructed. I don't expect everyone's going to want to delve into this, but I'm assuming that there will be some. With that, I want to thank everyone for their attention and participation. Look forward to seeing you in about 2 weeks. I want to thank all of our presenters and the staff behind the scenes that made this possible. I appreciate everyone sticking with us until close to 7 o'clock. You have a safe evening, and look forward to talking in a couple weeks. Take care.